There are a number of preclinical studies that have been done over the last almost 10 years, maybe more, looking at how histone deacetylase inhibitors and DNA methyltransferase inhibitors kind of work to prime the tumor microenvironment prior to treatment with, many different therapies. And in this case, we're investigating immune checkpoint inhibitors. And part of the reason that these drugs were thought to be good immune primers is because they do affect, most of the cells in the microenvironment, including the immune cells. And so some of the preclinical studies have evidence that not only do they affect the T cells, which are the primary targets of the checkpoint inhibitors that are most widely studied, being anti-PD-1, anti-PD-L1, and anti-CTLA-4, but also that the histone deacetylase inhibitors are affecting some of the more innate immune cells, such as myeloid-derived suppressor cells and macrophages. And that in some of the solid tumor types, especially that haven't previously been very responsive to checkpoint inhibition, the innate immune response has been shown to be really important as well. So the rationale is if you use these drugs that could actually affect the not only the adaptive immune response, the T cells that you're targeting with your checkpoint, but also the innate immune response that's primarily providing a suppressive tumor microenvironment, that perhaps you could actually get a more robust response to the checkpoint inhibitors in these traditionally quote unquote cold tumors like breast and pancreas. And so the preclinical data that preceded our trial was done, the papers Kim et al. It was in Bert Vogelstein's group, where they looked in some triple negative and colon cancer models to show that actually combining Entinostat with anti-PD-1 and anti-CTLA-4 improves survival in mouse models of breast and colon cancers. And this has also been shown by Roberto Pili's group in the renal cell carcinomas. And so the preclinical rationale was not just in improved survival and slowed tumor growth, but also that they showed an increase in infiltrating CD8 T cells, which is the primary goal of the checkpoint inhibitors. And then in addition, those same groups had looked into some of the innate immune cells, such as myeloid-derived suppressor cells, and also saw Entinostat is actually affecting the suppressive capabilities of these cells. So when I was a fellow at Hopkins in Elizabeth Jaffe's group, I started studying even more, looking into the mechanism of response of Entinostat on the tumor immune microenvironment, and had more data to support this clinical combination. Again, looking at the myeloid-derived suppressor cells and decreasing the immunosuppression within these tumor microenvironments, and that seemed to be potentially a reason why we actually see this influx of CD8 T cells. So does that help to kind of set the stage a little bit for sort of how we landed with this clinical trial?